Hello guys, sorry I'm a little bit late, had a bit of an issue there getting up and running. So welcome first of all to our Weymouth Physiotherapy Sunday Live. So it's the first one, so it's really cool that I'm doing it. Thanks for joining in. Wi-Fi's came on board, which is always a good thing. We're just going to give it a couple of minutes just for some other people to come on board. But if you haven't caught this live, then it is going to be posted up on the Facebook page anyway. So if you've got any questions based on it, just put comments in the post below and we will do our best to answer them and get back to you. So today the topic's going to be Achilles tendon injuries and their management. Okay, so if you've got any questions about any of that, you just send us a message right in the comment box and we'll address it hopefully in the talk. And basically get you helping out and moving forwards. Fine, so we're going to make a start. Okay, so we're going to talk first of all a little bit about what tendons are. So tendons are strong elastic structures, okay, that connect our bones and our muscles, okay, and in this case we're looking at sort of the gastroc and the soleus connecting up to our heel bone. So very important in things like walking and running. Now tendons are made up of two main things really. One is collagen, okay, and the other is what we call a ground matrix. There's a few other things in there, but those are the two main things that are on our tendons. And their purposes are to transfer load. So when our muscles contract, that energy gets transferred down into the joint to allow some movement. The other thing that they need to have is this energy storage facility. So particularly the Achilles tendon is really good at this. It acts a bit like a spring. So some tension gets applied to it through a stretch, and then it releases that tension, and that's called the stretch shortening cycle, and that's a really important part. So that's kind of what tendons are under normal circumstances, and we're now going to talk a little bit about what tendinopathy is. Okay, so tendinopathy is basically an umbrella term for all sort of tendon diagnoses. So first of all, you might get tendonitis. People often say that, and what we actually now know is that there's not a huge amount of tendon inflammation when we get these painful conditions. Okay, so that's kind of a bit of an outdated term, and that's why we prefer to use tendinopathy. Okay, so what tendinopathy is, ultimately it's a failed healing response. Okay, and when we have tendinopathy, we get several different changes within the tendon. So first of all, the collagen type changes, and it gets a bit kind of reconfigured, changes type, it just becomes a little bit less efficient at what it does. We also see lots of changes to the matrix. Okay, now the matrix binds a lot of water, and that's why we often see this thick swollen tendon, or you might get this tendon with this kind of hard knobbly bit on it. Okay, and the final change that we often see is what we call neovascularization. So this is where you get an influx of sort of blood vessels and nerves, and obviously that affects the tendon structure, makes it weaker, and also makes it more painful. So those are the changes that we get through tendinopathy, and what they are important, but we've also got to realize actually they don't always marry up with pain. So there are plenty of people out there who will have these changes in their tendon if we were to scan them and don't have pain. So they're important, but they're not the be all and end all. Okay. So we're now going to talk a little bit about who gets tendon pain. So there's three main people who will get tendon pain. Okay, the first is sedentary people. Okay, so these are people who perhaps don't do a great deal. They may be overweight, they may have other sort of comorbidities, diabetes, things like that. Okay, and one of the reasons these guys get tendon pain is because their tendons aren't getting regular loading, and with that they become weaker. Okay, and we start to see some of those changes we were speaking about before. So when they then suddenly just do something, and it doesn't need to be a lot in these people, that can often lead to sort of a painful flare-up of Achilles tendon problems. So that's group one. Now group two is sort of your people who are mild or moderate exercisers. They go out for walks, etc., things like that. And these guys will generally see a Achilles tendon problem arise when they start to change something. So they might start taking up doing more hill walking, they might start doing a bit of running, or they might just be simply walking more often than they were previously. I think that's one of the reasons, and at the moment I'm seeing quite a lot of Achilles tendon problems, is that a lot of people are doing this. People start to become a bit more active and started going out more for walks, and that's why a lot of people are struggling with their Achilles at this present time. So that's the second group. The third group are your sort of athletes, your people who are really keen on their exercise and do a lot of it. Okay, so these guys are obviously putting high demands on their tendons, and their bodies aren't repairing the damage that causes quick enough. Okay, they sometimes may have a change in how much they're doing loading. They might be training for an event and picking up the mileage, or they might be trying to get a certain speed, but sometimes these just come on just because of the sort of volume of the load that they're doing. So those are the kind of three groups. There's plenty of other factors as well that kind of influence people with tendon pains. Okay, so other things such as sort of your metabolic sort of issues, so obesity, diabetes, that certainly can have a predisposition to tendon health. Sleep, really, really important to get some good sleep to allow that recovery of the tendon so we don't start to see some of these changes. Biomechanics, of course, can have a big part. So if you run in a particular style or do have a weakness around a hip or something like that, that can mean increased loading on the tendon. And then the last thing is sort of hormones. So obviously hormones are a big part to play. And that's why we see this quite a lot in sort of post-menopausal women, particularly. We often see a big peak of that, and that's all to do with hormones. And then the final thing is more sort of psychosocial things. So things such as kind of faulty beliefs or fear, anxiety, that sort of stuff can also have a huge impact on how much pain experience a person experiences when they've got an Achilles sort of tendon problem, if you like. Okay, so that's the guys who will get Achilles tendon problems. And there's two types of Achilles tendon problems. So one is what we call insertional. So insertional Achilles tendon problems is right on the bone. Okay, so right where that tendon attaches. Okay, and we also have what we call a mid-portion Achilles tendinopathy, and that's probably the most common. So 80 to 90% of people will be a mid-portion, probably 10-20% will be insertional. And in terms of their management, their treatment, we manage them largely the same. All I would say if you've got an insertional tendinopathy is to try and reduce the amount of time you're stretching it and putting it at its end range, because it's particularly vulnerable to a sort of compressive force because it's so close to the bone. But ultimately the management is largely pretty much the same. Okay, we're now going to talk a little bit about the management of Achilles tendinopathy. Okay, so first of all, we've got to think about where we are. Is this tendon tolerating load okay, or is it really intolerant of load? So if you're getting pain during everyday activities, or you're getting pain that when you do load that tendon, it doesn't settle down for 24 hours or longer, that's a sign you've got a bit of an unhappy tendon. Okay, now in these cases, it might be sensible to try and get that pain under control. And we've got two kind of strategies we can use there. The first is sort of isometric exercises. So these are sort of where you do a static sort of contraction, and you do these for a long period, 45 seconds, probably about average, and that has been shown to reduce pain. But the most important thing is managing how much load you do. So we might ask people like this to kind of reduce their load by 50%. So it might be reducing their running or reducing their step count, and we generally say do that for 2 weeks. Now in extreme cases we might advocate total rest, but that isn't an ideal solution in tendon problems, because we need to have some form of loading to keep these tendons happy and effective. So total rest can actually be detriment to tendon problems. Okay, so we want to try and load you as much as possible. That process, we want to get that tendon a bit happy with load again, and once we get to that point, we can then start moving on to our sort of strengthening section. Okay, and there's many different ways in which we can approach this. The literature has 3 sort of main protocols described. Okay, so the protocols that you might see, and you can look these up, they're freely available. The first is what we call the Alfredson protocol, and the Alfredson protocol basically consists of eccentric exercise. So that basically means you're working against gravity. If you're a gym goer, you might hear that called a negative. Now this is a really nice simple exercise to follow. Okay, you basically come up on two feet up onto your tiptoes, lift 1 foot up and come down on 1, and it's generally advocated you do that on the stairs. Now you then do that 45 times with a straight leg, 45 times with a bent leg, So 90 reps in total, and you do that twice a day. So studies show that this is probably effective in probably 40 to 90% of people. So there's a bit of a varied range there, but there's a good chance that that particular protocol could be good for you. I like it because it's simple. Patients can follow it really easily. The downside is it's a big effort. It's twice a day of 90 reps of a very, very boring exercise. Okay. So it's not always the right solution for everybody. Yeah. Interesting, there was another study that looked at whether you had to do the 90, and there's some suggestion that actually doing it just till fatigue is probably adequate, and often pain gets in the way anyway. So that's one protocol. The other protocol is what we call the Silbernagel protocol, which is a bit more of a combined protocol. So that has what we call eccentrics. It also has isotonics. So isotonics means with movement, so against gravity and with gravity assisting. And it also progresses on to plyometrics. It's a little bit more of a complicated protocol to follow. To a layman without that guidance, it can be a bit confusing as to what you should do and when. But that said, the results have been shown to be on par really with the Alfredson protocol. So not hugely better, but on par. So it's an option. The one benefit of the Silbernagel protocol is it's once a day, so it reduces that need to do exercise twice a day. Okay, and then the third type of training that we can use for it is heavy, slow resistance training. Okay, so this is something we're kind of looking at more recently. Some people have been looking at that. Benefit here is it's 3 times a day. Okay, 3 times a week, so it's not at all regular. They're going to be using things like calf raises in a squat rack. They're going to use seated calf raises, and they're going to use calf pushes against a leg press machine, but with big loads. So you get a pretty similar response. Again, evidence, it's not supportive of that versus other. They're all about equal. Okay, the thing that all 3 of those share is that they're all progressive, so you have to add weight as time goes on. They all work the tendons heavy. Okay, so heavy loads but slow loads. Okay, so often our tendons can cope provided we load them up really slowly. So yeah, those are the 3 that you can look up, and if you want to kind of start those, then you can. My approach tends to be a bit of a combination of the 3. I like to use a bit of an individualized approach, depending on the needs of the patient, but also how that tendon's behaving. So I kind of flick between some of those strategies and make sure that you get back to that tendon recovery as quick as possible. In terms of running or doing your activities, can you continue to run? So the answer to that is yes. Okay, so you can definitely continue to run. We put some rules on that, okay, because we don't want to be aggravating the tendon. Okay, so we just need to make sure that we're not making our tendon pain worse. Okay, and so definitely do some running, but don't flare your symptoms up. And we can talk about that if you come and have an appointment with us. There's also other things that we might need to do. So we might need to address some biomechanics of issues elsewhere. We might need to address any thoughts and any sort of faulty beliefs that you might have regarding your tendons. We might look at sort of lifestyle changes, which might be really important: sleep, diet, exercise, weight, which can all have an impact in these types of problems. Okay. If things don't work, then the next steps are sort of more adjunctive care, sort of shockwave therapy, injection therapy is something to consider. The evidence isn't hugely strong for them, but it certainly can help in some cases. Thing to recognize with tendon problems is it's going to take at least 3 months. Okay, so tendon problems are slow. There are no quick fixes, but if you can keep active, you can keep doing your event. Hopefully you can stay with it and see the benefits afterwards. Anyway, that's all for now really. If you've got any questions, then do just post on the post that I put on the Facebook page any questions that you might have. If you want to speak to me about your tendon problem, I'll also put a link on the Facebook post where you can click on, give me your details, and I'll give you a call and we can talk about the sort of tendon problems that you might be having and how you can sort of move forwards with them and carry on with your sport. Anyway, thanks for listening. There's a few of you came in there. Ryan joined us nice and late, as always. Yeah, next week we're going to be talking about the best exercise for back pain, which should be quite a cool little talk. Preparing for that already. So look forward to that one. If you're interested, you've got back pain, then do log on. Anyway, Have a good rest of your evening. It's 2 now. I think we've missed Gaz's goal on the ITV. Take care. Bye.